Hello everyone, this is Chadi from CVI 2024. I'm really privileged to be with a panel today talking about a new technology for patients with aortic regurgitation. I have with me now is Nick Amoroso. He's a PI and recently has a publication in Lancet related to valve and aortic regurgitation, as well as Dr. Nadira Hamid. And we know her all together before from previous CVI interviews, talking from the imaging standpoint. Thanks for being with us.
Thank you very much for having us.
Yeah, I'll start with you, Nadira, now.
Yes.
Talk about, this is a different cohort of patients. Aortic stenosis, we understand the hemodynamics, the echo indication and all that, and which patient will go to what device.
Correct.
Aortic regurgitation is a little bit different. So tell us about how to screen and how to identify these patients.
That's a great question. I think, we always talk about tricuspid regurgitation being the forgotten valve. But we have realized that aortic regurgitation actually is also a forgotten valve for so long. And, all this while in treating aortic regurgitation, there's no dedicated TAVR devices out there in the market yet. And so valve is one of the first dedicated TAVR valve dedicated to aortic regurgitation. And in terms of screening these patients, I think the first and bread and butter is actually echocardiography. Like any other valvular heart disease. And, in the aortic regurgitation era, in terms of diagnosing aortic regurgitation, it is challenging, because the windows, we can underestimate it. The severity, a lot of it has been in the last couple of years, despite the guidelines of quantitative and qualitative parameters, it's really visual assessment. Yeah. And then a lot of these patients present to us in the community, and I'm sure, Nick will agree with us, that these patients will come with, by the end they come to us, it's kind of like in the end stage where the left ventricle is already dilated, the volumes are enlarged, the left ventricle functions are affected. And so it's, by the time you intervene with them, the remodeling effects to help them actually may be impaired. And so, the awareness now has been, thanks to society and people like you, that we are raising the awareness in terms of identifying these patients early on, before the left ventricle has been impacted, much so the right side of the heart has been impacted.
Exactly, yeah.
That's right. And so we, the echo community, are rigorous in terms of identifying these patients, do a lot of this quantitative and qualitative assessments. I've been fortunate to be part of the trial, the ALIGN-AR trial, and working with sites all over the country and the world, really showing them how do we do this, and if it's can't see it on echo, not to worry, do a transesophageal echo. And the other modality, like cardiac MRI, which is kind of the best modality of imaging to really show, and sometimes you have discrepancy as well. And that's where the team discussion is there.
To reconcile that discrepancies.
Correct, exactly. And so the threshold is really, if you're not sure, go to the next modality. Don't just stop there and let the patient. Because
you don't want to lose that LV or have a dilated LV because the train already gone by that time.
Yeah, I think that's critical, and it's something that we've been missing in the community for a long time, in large part because of difficulty with imaging as a whole, but that's gotten better. But also not having as many treatment options. I think there's been a reluctance to refer for many patients. In fact, we recently did an analysis of some AI collected data across about 30 health systems. And what we saw is that only 40, maybe 50% of patients with severe aortic regurgitation are being referred to a heart team. So even patients who have clear severe aortic regurgitation by their echo are still not being evaluated for therapy as much as we would expect.
Because by default now, if you see aortic regurgitation, it's a surgical anatomy, has to go to the surgeon. And if the surgeon turns them down, that's it, the patient has no option. I think everything stops at that point.
That's right.
So tell us about the trial, and congratulations for the new publication in Lancet. So tell us about the trial, just to go over a view of the topic and how we are, what the main result.
Well, we were excited that with the ALIGN-AR trial completed enrollment and published its one-year data in Lancet earlier this year. We were excited to see that we had a safe and effective treatment using the valve trilogy system. And by being able to provide TAVR for these high-risk surgical patients, And we saw improvements in KCCQ scores, NYHA, a functional class, and their mortality remained low. So we were very pleased.
Do you have a follow-up for these patients? How long was the follow-up post-implantation?
So these were the 1-year data, and we'll expect to follow them out to 5 years, of course. So we're looking forward to multiple publications in the future to further describe what this disease state is, as well as what we see for long-term treatment through transcatheter therapies.
So Nadira, you're the core lab for ECHO. So post-implantation, how was the hemodynamics?
Oh, wow. And, I have to say it's excellent. The unique thing about this is that this is the aortic regurgitation instead of aortic stenosis. And, you don't have much calcium, in the annulus. And so the hemodynamics for this, the valve areas are actually relatively larger than we see post-implantation and throughout the follow-up as well. So excellent mean gradients, the valve area as well, obviously at 1 year, and we're still following up for the long-term durability. And the other thing, which, from the echo perspective, obviously you would ask about the paravalvular leak.
Which is more concerning from that anatomy.
Correct. And, the great thing about this is that we see very little, like mild or more paravalvular leak. And actually I have a case where it actually has slightly more than mild, maybe close to moderate. And over a period of time, it actually regresses. And presented it at TCT last year. And, part of it is we are understanding the valve itself is a self-expanding. Mm-hmm. That's right. And so it has the calcium to kind of,
anchor. Yeah.
Right.
Yeah.
Correct. And the mechanism of anchoring is through the leaflets, the clipping. And so, over a period of time, it has the ability to expand. And we saw a couple of cases, actually, a handful, that the paravalvular leak actually regresses over time. So that is really reassuring.
Absolutely.
Exactly.
Yeah.
And so procedurally, if you see mild, I think it should be okay rather than really, post-dilating it and,
give it some time.
Correct.
From a technical standpoint, now, as Nadira mentioned, there's no calcium to implant. So was it difficult? Any challenges? Any different things that as a self-expanding valve during implantation?
Yeah, in comparing to our self-expanding experience with aortic stenosis, there were some skepticism or concerns early on about what we were going to see or what to expect. But as we gained experience, it became much more straightforward than we initially thought. The engagement of the coronary cusps or the leaflets themselves of the aortic valve with the locators on the inner valve kind of help paperclip almost to the valve. And so once you have achieved locator alignment, you can feel pretty confident that you're going to have great coronary alignment. You're going to have kind of depth protection in your implant so it doesn't sink too deep. And that your valve is going to align very coplanar to the annulus. So it became surprisingly easy, I'd say, as time went on and we had more experience with it.
But that's as any devices before, the more you do, the better you get, and you find fine-tune the skills or the device itself down the line. But again, congratulations for publication, for a new therapy for patients, and this is very promising for patients with AI.
Absolutely.
Thanks for joining us on CVI TV. Please watch these videos and others on CVI YouTube channel. This is Chadi from Denver, Colorado.